Well, thank you for tuning in for today's CE webinar from the Society of Palliative Care Pharmacists. We're glad that all of you could join us. We are accrediting this for continuing education through Southern Illinois University, Edwardsville. There will be some information at the end of the presentation that will be given to you. Please stay tuned for that info. Go.
All right, good afternoon, everyone. Thank you for coming today. I'd like to introduce our speaker today, Dr. Brittany Johnson. She's a PGY2 Pain and Palliative Care resident at UF Health here in Jacksonville, Florida. She's a graduate of the University of Florida School of Pharmacy, and she did her PGY1 residency here at UF Health also. So without further ado, I'd like to introduce Brittany Johnson.
Thank you for the introduction, Dr. Camilleri, and thank you for everyone who tuned in today. I'm very excited to get to share about this journal article with you and just come together as colleagues in the same area of interest. So before I get started on the topic, I just wanted to kind of give a brief sort of intro as to why I chose this particular paper. And as pharmacists, we get a good amount of introduction to the outpatient pain management for our individuals coming in on the clinic side, but we don't get a lot of exposure to interventional pain management and those things that we can do as pharmacists to try to incorporate some unique ideas or primary literature that may be applicable in taking better care of our patients. I think nationwide we're hearing a lot about HCAP scores and trying to get patients' pain to goal, and we're struggling with that. And so using as many modalities as possible, whether that be co-analgesics, interventional pain, whatever that may be, we're all working for the same effort to get our patients' pain well managed and under control. So just going into any disclosures, unfortunately, I'm not fancy enough yet to have anything to disclose, but hopefully one day in the future. So I have no conflicts of interest relative to any products or service presented in this discussion or activity. My objectives for today will be to explain briefly the use of ketamine in pain management, just to get us all on the same page. And then we'll identify ketamine's potential role in modified pectoral blocks, which we'll discuss through this article, and sort of compare the interventional block methods with the addition of this novel ketamine therapy so that we can optimize patient pain outcomes. So just to provide you a little bit of background, first off, I think it's important that we note how prevalent breast surgery is in the United States especially. It's becoming an exceedingly more common procedure. As we develop with our ultrasound technology, our CT, our imaging, we're getting better and better at diagnosing breast cancer early. And breast cancer is the most commonly diagnosed form of cancer found in women. It's not the most deadly, that's still lung cancer. But breast cancer is very prevalent in the United States, affecting 1 in 8 women with an invasive type of breast cancer that may be candidates for this interventional mastectomy. And it's common for these individuals to experience acute pain following their breast surgery, but even more so, we're seeing women with delayed onset chronic pain going up to 25 to 60% of individuals, even up to 3 years out from surgery, which I found to be pretty astounding just in looking at those numbers. Now, conventionally, most approaches are going to be utilizing the paravertebral blocks prior to initiation of surgical intervention in these mastectomy patients. However, more novel therapies are being utilized with the peripheral nerve block as an alternative, and we're going to talk a little bit about the modified pectoral block specifically today. Now, with the paravertebral block, it's relatively straightforward in that the anesthesiologist will pick 4 basically trigger point areas on either side of the spinal column. This tends to be a relatively effective method to utilize for interventional pain management. However, there are those instances where the patient may not be a candidate for using the spinal approach, so they'll go in on the anterior plane of the intercostal region. And I'll show you some pictures of that later on, just to kind of get us all on the same page. But either way, this new paravertebral, compared to the pectoral block, is something that anesthesia is really discussing more at our institution. So I dug into it a little bit deeper in my exposure on rotation. So this may be an option for us moving forward in the setting of mastectomies. And you can't really go to any pain conference right now without hearing something about ketamine. Ketamine has been around a very, very long time, but we're starting to use it in new ways. And that's exciting from pain management perspective for us. But just to, ensure that we have an understanding of some of the complexities that surround the drug, I just wanted to give you a brief background. So ketamine can be utilized for a variety of things, anything from status asthmaticus to your opioid tolerant substance abuse patient that admits to your ED. It has both sedative properties and anesthetic properties, and very potent marked analgesic effects, acting very quickly when we compare it to morphine and other agents that we've typically utilized in the past. It acts on receptors in the cortex and the limbic system by non-competitively binding to those NMDA receptors. However, as most of us know, that's really not the whole piece of the puzzle, because ketamine also has all these ancillary activities that we're still learning more and more about. So we have the opioid receptor binding affinity that occurs, also our D2 and our 5-HT2 receptor activity. It does a pretty good job of inhibiting some of those ion channel activities as well, to slow down some of that central windup that we hear about, or central sensitization that we're concerned of. And then, decreasing the inflammatory cascade and mediators that occur as well. Some of the concerns that people have surrounding the utilization of ketamine, is that this sympathomimetic activity. So is there tachycardia, hypertension that we need to be concerned about? Myocardial and cerebral oxygenation consumption can be altered, as well as cerebral blood flow and intracranial pressure. So this leaves some clinicians still a little bit unsettled in that we don't have a lot of longitudinal data, but welcome to the world of pain management, right? So, additional concerns with utilizing ketamine in this role is that the benefits in pain score reduction that we see among the literature has varied greatly depending on the location of the injection, if it's being used for regional or local purposes, also the level of tissue inflammation, and the timing of the injection in relation to surgical procedure or debridement, whatever is occurring for the patient. Also, as you review the literature, you'll find that the dosing schemes vary widely among this agent and how it's utilized in different patient populations. So it just adds a little bit of complexity and reduces the comfort level of many practitioners. But its efficacy has really been something that's made it worthwhile to at least start exploring a little bit more. So since the majority of us here today are pharmacists, this was something that I felt was important to kind of break down, because before I started getting involved on the inpatient side, I really didn't know very much about the interventional approaches. So what we're going to be discussing today is a modified pectoral block approach, also known as a PEC2 block, if any of you out there are familiar. And this is conducted under guided ultrasound. So in this study, what they did here is they went in, I'm not sure if you can see my mouse, but in between pectoralis major and pectoralis minor, they injected using a 21 gauge needle, either bupivacaine alone or bupivacaine with fentanyl. And I'll break down the study model a little bit more, but just to get you oriented. And then also they did 10 mLs there, and then an additional 20 mLs of bupivacaine alone or bupivacaine with ketamine in between pectoralis minor and the anterior portion of the serratus muscle. And this is going to block in your intercostals. This is going to block 3, 4, 5, and 6, and that's going to provide you coverage for your thoracic, like T2 through T6. Okay, so just to give you an idea of what kind of coverage that we're getting for these mastectomy patients. So getting into the journal article, the journal I chose was The Efficacy and Safety of Ketamine Added to Local Anesthetics in Modified Pectoral Block for Management of Postoperative Pain in Patients Undergoing a Modified Radical Mastectomy. So this journal was published in Pain Physician in October of this year. And just to give you some background on the journal itself, Pain Physician is an official publication of the American Society of Interventional Pain Physicians, also known as ASIP. They publish 8 times per year, so not on a monthly publishing schedule, but the information in there is really going to be more focused on interventional pain management. So it's peer-reviewed through multiple disciplinary contributions, both written and directed, more so by interventional pain physicians and clinicians. Is Alan David Kay, who's an MD PhD. He currently resides at LSU School of Medicine, where he serves as the director of the Department of Anesthesia. And he has a pretty impressive curriculum vitae. If you review it, he's got over 500 publications in the area of pain management and interventional pain. So well suited to be the editor-in-chief of this journal specifically. Also, for those of you in the academia world that may be interested, the impact factor for this journal is 3.52. And looking at the authors of our publication, these authors disclose no conflict of interest, just to preface it with that. But our primary author is Ahmed Othman. He's a professor of anesthesia at the South Egypt Cancer Institute, which is affiliated with the institute that this study was conducted in. He provides lectures on critical care as well as anesthesia and pain relief there. Our secondary author is Ahmed Al-Rahman, and he's also a professor of anesthesia, providing lectures in similar areas on pain management. He's also affiliated with the South Egypt Cancer Institute at Asut University, and this is where the study was conducted. And then our third author is Fatma Sharif. She is the correspondent listed for this paper, and she's also doing some additional research currently in the use of ketamine for wound infiltration, comparing that to Precedex with bupivacaine in surgical stress. So I think this is a very appropriate team to be writing on this topic. They're all specialized in the areas of anesthesia and pain management, so well suited for publication of this article. So getting into the article, the purpose of this article was to compare the analgesic efficacy and safety of modified pectoral blocks, looking at ketamine plus bupivacaine versus bupivacaine alone. And this is going to be in patients undergoing breast cancer surgery. This was a randomized, double-blind, prospective study. It was conducted at an academic medical center in Assault University's South Egypt Cancer Institute, which is located in Scotland. And there was no external funding in the preparation of the manuscript or the study itself. Approval for the study was granted by the Ethics Committee of South Egypt and the Institute at Asut University. Getting into the methodology, relatively small sample size here, but that tends to happen oftentimes when we're dealing with pain studies anyway. So 60 individuals were included in this study, ranging from age 18 to 60 years old. So elderly population not very well represented here. The American Society of Anesthesiologists classification of these individuals had to be either class 1 or class 2. And for those of you that are not familiar with the scaling, the ASA scale goes from class 1 to class 6. So class 1 is going to be your normal healthy patient. So no organic, physiologic, psychiatric disturbances, excluding the very young and the very old population. And they have to be in very good health with an appropriate exercise tolerance for their age. Now, those, ranging more at the end at 6, that's going to be patients declared brain dead that are potentially being considered as for organ donation. So for these patients to be class 1 and class 2 only. They either had to be a normal, healthy patient outside of their breast cancer diagnosis, or patients in class 2 would be those individuals with a mild systemic disease, but it couldn't provide any functional limitation. So they had to have a well-controlled disease, only one comorbidity for their body system. So if they had hypertension, they had to have controlled hypertension. Diabetes, if they had diabetes, it had to be without any systemic side effects or consequences of that. If they were a smoker, they couldn't have any COPD from that. They could be only smoking alone. So you can see here, we're starting to very quickly narrow down our patient population. Body weight ranging anywhere from 50 to 90 kilos. So that's anywhere from basically 110 to 200 pounds. And then, of course, being scheduled for a modified radical mastectomy. So in looking at this, when we're thinking about my patient population at our institution here, the generalizability of this becomes greatly reduced just based on the ASA classification as well as body weight, because most of my patients are typically going to be overweight and have multiple comorbidities by the time that they present to us because of the indigent population that we serve. But there may be other institutions that this would be more in line with. Just something to consider as we review the article. So patients that were excluded from the study were any of those individuals with a history of bleeding, diathesis, which is predisposition to any particular disease state or heredity leading to any abnormal allergies or disorders that they may have previously identified. Patients with a relevant drug allergy to the agents being utilized, opioid dependence, sepsis, prior surgery in the supraclavicular or infraclavicular or axillary regions, alcohol or drug abuse patients, anyone with advanced cardiovascular disease was also excluded, and then psychiatric illness that may interfere with the patient's ability to perceive their pain appropriately or provide an adequate assessment. And again, looking at this exclusion criteria, the majority of patients that we're seeing utilize ketamine utilized in are oftentimes those individuals with a substance abuse history or opioid dependence. However, this agent is being used more locally here, but these are just things to think about when we're assessing the inclusion and exclusion criteria a little bit more critically for generalizability in our patient population. So preoperatively, patients were educated on the visual analog scale, and with 0 being no pain, 10 being the worst pain that they could imagine. Now, the length of education time or who provided this education was not noted in the article, so I'm not sure if it was delivered by the provider or nursing staff, or how far out that education occurred prior to the surgical intervention, which is something that I would have liked to have known, because that could influence the patient's understanding and interpretation of that scale. All patients received 10 milligram dose of diazepam the night prior to surgery. And for the anesthesia cocktail utilized, it was fentanyl at 2 mics per kilo, propofol at 2 to 3 milligrams per kilogram, lidocaine 1.5 milligrams per kilogram. And then interestingly, they used cisatracurium at 0.15 mg per kilo for endotracheal intubation. I'm not sure if they chose cisatracurium because of the esterases that break it down, so you don't have to worry about as many of the hemodynamic concerns. However, typically I don't see that commonly used as an agent, but I don't think that would influence our outcomes in this study. So breaking down our control group and our ketamine group, both agents were delivered via ultrasound-guided modified pectoral block. And 30 mLs of the 0.25% bupivacaine was divided out. So 10 milliliters was injected between the 2 pectoral muscles that I showed you earlier on that interfascial plane. And then the other 20 milliliters were delivered between the pectoralis minor and the serraceous anterior muscles that I highlighted. Now, the only thing that differed in the ketamine group was that a 1 mg per kilogram dose was delivered in that same 30 ml combination with bupivacaine. So divided out with the 10 mLs between the two pectoral muscles, and then the 20 mLs injected between pectoralis minor and the serraceous anterior muscles. Okay, so same location of delivery. The only thing differing between the two groups is going to be the addition of the 1 mg per kilo ketamine. Now, following surgical intervention, these patients were reversed using neostigmine as well as atropine if necessary. And after extubation, they were taken over to the post-anesthesia care unit, which most of us called the PACU, and they were initiated on a morphine PCA in the PACU immediately post-op. So an initial bolus was delivered at 0.1 milligrams per kilo of morphine as a one-time dose for those patients that either reported being in pain or rated their visual analog scale to be greater than or equal to 3. This was followed by then 1 milligram boluses at a 15-minute lockout interval with no basal rate provided, so only on-demand dosing being delivered in the PACU. Now, all patients were followed at baseline 1 hour, 2, 4, 6, 12, 24, and 48 hours. Now, authors went on to evaluate heart rate, any blood pressure changes, respiratory rate, oxygen saturation, and then, of course, what we're most interested in is that change in VAS score. In addition, they took into account time to first request of rescue analgesia, the total morphine consumption over the 48-hour period monitored, and then any potential side effects, including sedation. Now, just to brief you and orient you to the sedation scoring system that they utilized, and they utilized a 0 to 4 scale, with 0 being fully awake, 1 being somnolent, responsive to verbal command, 2 being somnolent and responsive to tactile stimulation, 3 with the patient being fully asleep and responsive only to painful stimuli, and then 4, the patient is just simply not arousable. Now, looking at the patient population demographics provided in Table 1 for this study, there was no significant difference noted among the two groups regarding the demographic data. Patients were typically averaging in their mid-40s with an average weight of about 70 kilograms, which is like an ideal patient. I don't know where they got these patients. These are like golden goose patients. With the majority of these individuals also being ASA class 1. So again, those are going to be your normal healthy patients with no organic, physiological, or psychological disturbances outside of this breast cancer diagnosis. And on average, as you see, the duration of surgery lasted approximately 3 hours between both groups. So no significant difference in population design. The statistical methods utilized, I'll further discuss on the next slide, but they set their power at 80% based on their sample size calculation. They would need to have 30 individuals in each group to do that, which they did meet with no dropouts. Their alpha was set at 0.05, and that's basically going to be our risk of having a type 1 error. So by selecting an alpha at 0.05, we're saying that we're accepting a 5% chance that we're going to identify a difference that really is not there. So that's leaving us a 95% confidence interval, and a p-value set at 0.05 for a statistically significant difference. Now, for our qualitative values, they utilized chi-square, which is typically going to be our information that we can put into some sort of category, right? And then the Mann-Whitney U test was utilized to compare data between 2 quantitative variables. And the Wilcoxon signed rank test was used to compare quantitative variables that may have had skewed data in there, so non-parametric data. So all of these statistical analysis were appropriate based on the data set that was collected. Now, starting to look into the study results, the meat and potatoes of what we all are here for. When we look at systolic blood pressure, just to orient you to the axis here, on the vertical axis, we have systolic blood pressure in millimeters of mercury, and then on the horizontal axis, you can see time from baseline, which baseline was the time immediately post-operative after extubation of these individuals, and then extending out to 48 hours. Now, in your ketamine group, listed here in the diamonds, and this will be done throughout the remainder of the graphs that I show. And the control group is your green circles there. As you see here, there's no statistically significant difference between the two groups at any time point with regard to blood pressure, but you can see blood pressure ranged anywhere from 120 to 125 systolic for these individuals. Looking at diastolic blood pressure, we see the same, no significant difference between groups here, with blood pressure ranging somewhere between 74 and 76 millimeters of mercury for diastolic. So really ideal blood pressure in these individuals also, which we would expect given the very healthy population that was selected for this study. Looking at heart rate ranged anywhere from 74 to 80 beats per minute with no difference between groups here either. So just showing that the hemodynamic, some of those hemodynamic concerns that we may have had with the utilization of ketamine, we're really not seeing that in the data presented here. And then respiratory rate, interesting spike occurred at about 24 hours, which you would, when looking at this graph, you would think, oh wow, they really spiked up here. But if you look at the parameters of the vertical axis here, we're talking anywhere from 11 to 14 breaths per minute in the respiratory rate. So really not clinically significant, and was not found to be statistically significant either when looking at ketamine versus the control group, but ranging somewhere between that 12 and 13 breaths per minute on average, which is clinically appropriate. Oxygen saturation also did not show any statistical significance between groups. And, you know, as we see here over that 48-hour period, patients remained well saturated, anywhere from, you know, 99 to 99.2% for their O2 sat. So no concern there with the addition of ketamine in this setting either. Now, as far as the visual analog scale in the study groups is concerned, looking at the average post-op visual analog score in these individuals, the values showed no statistically significant difference between the two groups at any of the time points at baseline to 48 hours. However, numerically, we see a lower value when we start looking at 12, 24, and 48-hour time points with ketamine. But this is, you know, a very small amount. We're looking at, you know, 0.1 on the visual analog score. So from my opinion, not very impressive from that standpoint. Now, what becomes a little bit more clinically impactful is when we look at the study results for the time to first request of analgesia. So just to back up a little bit, only 8 of the 30 patients in the ketamine group required that additional morphine bolus. So they would have had to report their visual analog score to be greater than 3 to even be administered that first dose of morphine. Now, 18 of the 30 patients in the control group with the bupivacaine alone required morphine administration to keep their visual analog score less than or equal to 3. Now, there was a significant difference in the time to the first request of analgesic therapy as well. So when we look at the ketamine group, it was significantly prolonged compared to the bupivacaine group alone. So looking at roughly 18 hours to time of request compared to 13 hours in the control group. So over a 48-hour period, we're looking at a 5-hour reduction in the amount of time to request the analgesia from the control group over ketamine. And that was the p-value of 0.001. Now also there was a significant difference in the decrease in morphine, total morphine dose consumption over that 48-hour period. When you look at the ketamine group, you can see it was roughly 13 milligrams of morphine compared to the control group, more at 19. So roughly a 6 milligram difference, give or take, in a range there. And I would argue, maybe this isn't profound reduction, but when you're looking at over a 48-hour period, this may justify utilization of ketamine as a co-analgesic in this setting, because we are still reducing the overall morphine burden. Now, looking at that sedation score that we previously talked about, ketamine had a higher baseline sedation for patients, but quickly oriented at 1 hour and followed nicely in line with the control group after 48 hours. So there was no significant difference in sedation score between the two, but there was a significant decrease in the sedation score from baseline across that 48 hours within the group, which is to be expected, because as these agents begin to taper off, the patients are being rebolused, we expect them to clear, and that's exactly what these individuals showed here. Now, getting into some of the adverse effects. So looking at the comparison of the hemodynamic parameters, we've, relatively well put at rest any concerns for alterations in heart rate, oxygen saturation, blood pressure, hemodynamic changes from that perspective. But there is a good amount of literature out there supporting this increased incidence of nausea that we can see with utilization of IV ketamine. And it falls in suit here when looking at the side effect profile of the local administration. So in the ketamine group, you can see that there were 3 individuals that reported nausea. 2 of those individuals went on to actually experience vomiting as well, with no other symptoms of this being reported in the control group. So this does go on to support that, we do have to be concerned about some of the nausea and vomiting that can be accompanied by ketamine administration. But no other side effect concerns were reported with regard to chest pain, hallucinations, delirium, arrhythmia, or any other category that was expressed. So, relatively moderate safety profile from these parameters that were measured. However, the nausea and vomiting can be a complex issue. When we went to recent Pain Week conference, they discussed that a lot of patients will undergo higher levels of pain in order to avoid the nausea and vomiting that can occur by taking these medications. So it's really something that we have to weigh out based on the patient's history. Also, because this is a smaller sample size, this may be much more robust if we expanded it to a larger patient population. So really taking into account your patient's history as well as their risk of emesis. Now, the patients that did go on to have vomiting were treated with Reglan, and their nausea did resolve. The authors did not go on to note the duration of time that it took this nausea to resolve, or how many doses of Reglan were administered for resolution. So in conclusion, the addition of ketamine to the modified pectoral blocks prolonged the time to first requested analgesia, which we said, was roughly 5 hours. So when looking at that from a clinical standpoint, I think if you have a patient that's coming in for an outpatient procedure, this can be significant. So we're able to get the patients home faster, feeling better, and start their PO regimen on the outpatient side instead of having them delayed here as a pain control issue. It also reduced the total opioid consumption without any serious side effects aside from the nausea and vomiting, but I wouldn't classify those to be serious in this case. But we're seeing a 6 milligram reduction in our overall morphine equivalent consumption is significant in my opinion. Now, we do a lot on the outpatient side, just trying to preserve 10 milligrams of morphine a day by adding on Lyrica and gabapentin, or our anti-inflammatories, other agents. So, while this may be a minor reduction, I do think that it is significant for a patient population. Looking at the overall clinical application, there may be value in adding ketamine to local anesthetics for peripheral nerve blocks. However, this study was conducted in an ideal patient population. As we discussed earlier in the talk, these patients were, limited in their comorbidities, appropriate weight, high functional scales. They also didn't have a history of any opioid utilization, no substance abuse history. So really, these are our ideal patients. What I would be more interested to see are those individuals with higher complexity pain states coming in with this additional intervention on top. And then this drug combination in pectoral blocks specifically needs to be further investigated with larger numbers of patients to kind of expand on those adverse side effects that we talked about, as well as continuing to look at those hemodynamic parameters that may exist with the utilization of ketamine. And using a variety of ketamine doses and local anesthetic agents in combination to see really what our optimal dosing regimen would be. Now, when you review the literature on this, there's very limited information with the utilization of ketamine in modified pectoral blocks in general. But when we look at ketamine utilization for either local or regional anesthetic, it can range anywhere from 30 to 50 milligrams, so weight-based dosing. And those agents are used in different settings, so either infiltration for INDs, they're utilized for local anesthetic blocks, but in different areas. From what I've read in the literature, the higher the level of inflammation in the tissue, the more likely that this agent will be effective. So really looking at a wider span of what dose is appropriate and what tissues and in what patient populations is going to need to be more robust before I think this would be considered by your P&T committees and things like that. And then extended, a long-term follow-up period to explore the chronic post-mastectomy pain benefits. So as I mentioned previously, patients, experience this pain up to 3 years post-operatively. So are we seeing any benefit maybe using ketamine early on for that central sensitization and wind-up that we are concerned about in the chronification of pain? Is this going to be beneficial down the road? So we may not see a huge reduction in morphine equivalents or duration of pain experience, but what are we seeing on the extended side? Because that's something that we on the outpatient side have to worry about dealing with as well. So I also wanted to provide those of you who participated in the talk today with the following access code that you will need to complete your evaluation of this CE. And I believe there are also some follow-up questions for you to answer. But the code for that is JXFL. That's JXFL. And at this time, I'd be happy to take any questions that you may have for us to kind of discuss a little bit about what your thoughts are, what you may have seen on the outpatient or inpatient side with these individuals. I know that it can be, anytime you're dealing with that intercostal region, it can be very complex to manage these individuals because they're typically mixed pain types. But also any inpatient knowledge that someone has out there, I'd be happy to discuss and share as well. Do you have a question? Not sure if we're having some technical difficulties. Please bear with us. Let's see, invite.
You see that?
If I had to redesign the trial, okay, so we have a question here from Michelle. Thank you very much for logging in, Michelle. She asks, if you had to redesign the trial, what would you choose as your primary endpoint considering the non-significant difference in pain scores? So I think that there are a couple of things that I would change about this trial design. First off, the patient population included, I feel that the individuals selected here were too limited in that the people that we're looking at, like I said, are kind of this golden goose population, right? So their ideal weight, they have high functional capacity, not your typical patient that's going to present to the OR, at least not in my patient population. What I would like to look at, a lot of these times this can be an outpatient-based procedure. So patients are admitted the day of, they'll receive their interventional block, and then hopefully later that day or the next day go home. Unfortunately, some of the individuals that we come into contact with end up being hospitalized due to pain control issues. So one thing that I would like to look at would be length of stay or overall time occupied in the PACU, because that is a high turnover area. Sometimes getting patients in and out quicker would provide, increased OR turnover, and then that's how hospitals generate dollars. The other thing to look at, I know that the average pain scores didn't differ statistically between the groups, but I think that they were appropriate in looking at time to first request of morphine, as well as the overall utilization of opioids, because our whole focus is to try to reduce opioid justified by what those parameters that they looked at. So I do think that piece of it was appropriate. I probably would have taken one of those as my primary endpoints, with looking at length of stay and duration in the PACU. One other thing that I would have liked to know also would be the number of doses to resolve the nausea and vomiting, or the duration that the nausea and vomiting was experienced, or if those patients received anything preoperatively, would that outcome have been different? So here at our institution, we give a pre-op antiemetic dose to try to reduce that risk. So there may be some things that it could have curbed those side effects that were not evaluated in this study design. Did the authors give, oh, you're welcome, Michelle. And Kenny Jackson is asking if the authors gave any information on the dose they selected. So they utilized a 1 milligram per kilogram dose of ketamine for the pectoral block, which was mixed in, they didn't give us the exact volume that came out to, but that was mixed in with the bupivacaine, which was delivered at 10 milliliters in between the pectoral muscles, and then another 20 milliliters delivered in between the pectoral space and that serrational anterior pocket. So really the goal is to provide T2 to T6 coverage. However, the efficacy of that full block was also not evaluated. So typically in patients, they'll utilize what's called an ICE test and run up the abdomen to make sure that they have appropriate coverage. So they'll stick the ice on the patient's hand, ask them, do you feel this? Yes or no? Is it cold to you? And then they'll place it on the abdomen and work up the thoracic cavity to ensure that they have an appropriate block. So efficacy of that block was not defined here, but the 1 mg per kilo dosing was what was utilized. The volume of ketamine, so Kenny goes on to ask if the volume of ketamine would influence the results. That is hard for me to speak to. I don't know that necessarily a volume issue would have influenced outcomes, especially with regard to what they were measuring and with pain scores. I do think that the concentration as far as the dose of ketamine utilized could provide influence, which in these modified pectoral blocks, this is the first study to actually utilize ketamine in this approach. Now, when you look at other studies, they range anywhere from 30 to 50 milligrams, and they do show positive outcomes. However, when you compare them to, that's comparing them to your standard of care with just bupivacaine alone. There's not a lot of literature out there comparing it to ropivacaine or comparing it to any other methodologies of intervention. So it's hard to say what the appropriate dose or volume of delivery is. And I think that's one of the weaknesses with utilizing ketamine in a lot of these different roles that we're looking at right now, because dosing variability is so huge. And that applies to, your pain management with your IV and continuous infusions of ketamine, as well as the interventional setting. So I think they're still sort of too new to really say and tapping into that. Thank you.
Are there any other questions for Dr. Johnson? Well, thank you very much for tuning into our second CE webinar presentation from the Society of Palliative Care Pharmacists. I think that we need to, do we need to give a CE code, Brittany?
I did, but I'll give it one more time just in case. So your CE code for access to complete your evaluation of the CE is JXFL. That's JXFL.
All right.
Okay.
Well, you did a wonderful job. Thank you so much for doing this.
Thank you for having me. Yes. Thank you, everyone, for coming and for your contributions.
Thank you, Brittany.
Goodbye.
Thank you. Have a great Thanksgiving, everyone.
You too. Happy Thanksgiving, everyone.